Hello, ladies and gentlemen. I would like to welcome you wholeheartedly to this year's symposium. This year's conference is called "What has the healthcare learned from the COVID-19 pandemic?" As every year we are touching upon the issues of the healthcare system. This year we would like to focus on how the COVID has impacted the fact of thinking about transformation in the healthcare system and what conclusions we have met. As you know, the COVID pandemic is a new challenge in every aspect, including for our health and for the healthcare system. It has been over almost 2 years in December of the new reality. And now we know that COVID is here to stay, just like the flu. As of the 1st of October 2021, over 233.5 million infected have been confirmed, of which 4.8 million have died, which shows that we are still in the middle of the pandemic, and it is possible that 2 or 3 years to come will also have a similar figures, despite of the fact that many countries have adopted various ways of dealing with the new reality. In all countries in the world, there are discussions on how the systems should evolve, how they should transform to accommodate also rapid reactions to epidemic challenges. Access to vaccination has become one of the key challenges of the healthcare for the years to come. We have to keep in mind that our health right now globally is very correlated, and the new COVID variants will also give rise to new challenges, both to science and to the healthcare systems themselves. Very often, COVID is compared to the Spanish flu that originated in 1918. We have to keep in mind that we have taken the same actions to limit the spread of the virus. The Alpha variant, as you know, used to infect mostly senior citizens and people with comorbidities, while the Spanish flu was a greater burden on children and people aged 20-40. This is still ahead of us. I think that the Delta variant is changing our view on the situation, and we know that new variants will come. And this awareness that different countries can react differently to the challenges posed by COVID, we have to keep in mind that other diseases did not stop to exist, and that other patients also require treatment of civilization diseases and the previous disorders related to other diseases as well. All those disruptions related to the pandemic have led to the deterioration of various aspects of our life related to our work and families. And these are effects that we will be observing in the years to come. We know that the pandemic is changing work-life trends, also brings to the table a lot of remote work and remote teaching. The situation that we faced in the years 2021 continues to be a challenge for many people, and this will have an impact on our mental health. We also know that on average we have put up several kilograms of weight, and alcohol consumption has been increased on average in many countries. We also have to keep in mind the shifts in the job market, which will also impact the mental health of people. So the quality of healthcare, which has become a slogan often repeated, it has become the reality right now. For the first time, we have had this rare decision and rare situation where we had to introduce solutions which we don't know what effects will bring. And when we started the pandemic, we knew very little about COVID-19. But after almost 2 years, like I've already said, access to vaccinations in some countries is very well developed, in particular where there is universal access to healthcare, like in Europe and CEE countries. We want to think about how digitization of healthcare and access to new data, the possibility of analyzing prospective improvements of the system has become reality. And therefore it is key to think about how the new perspective and innovativeness on looking at healthcare can bring better effects to all of us, not only in Poland and the countries of our region, but globally. And that is what we would like to discuss during our 16th edition of this symposium. So I would like to welcome you wholeheartedly. Thank you for hearing us. Thank you for listening to us online again. And I hope that we will be able to meet you next time in Krakow in person and celebrate the possibility of meeting and exchanging experiences. Thank you very much. And now I would like to give the floor to Tomek. Thank you very much. I would also like to welcome you with all my heart. We have a fantastic agenda for today, which is quite full, actually. We are being watched by more than 270 people. And just like last year, we also have a chat ready for everyone. We have this request: do not be confused if we do not answer immediately. This is a moderated chat. We will probably be able to address only selected questions during the symposium, but afterwards we will definitely answer all questions. Please ask the questions in the chat, which is in the window to the right of the main stream. The discussion, which will be held right after the lecturers.
Pan minister Krzysztof Łanda. Zapraszamy do aktywnego udziału. Oddaję głos Magdzie.
Now I'm giving back the floor to Magda. Ladies and gentlemen, we are starting with the first session from drugs, from market authorization to reimbursement. The first speaker is Marion Benny from Scotland, who is the professor of pharmacy and epidemiology at the University in Scotland. Marion,
I would like to welcome you in the conference. It's a pleasure to see you, and we're waiting for your experiences and knowledge regarding the drugs in Scotland. Marion? In some technical problems, we don't hear you. Marion will present medicine intelligence in Scotland as a support of health policy and in an improvement in outcomes for patients. Do you hear me? Przepraszam Państwa chwileczkę. Przepraszam, studio, czy mamy jakieś problemy techniczne? Marion, could you wait? That is some technical problem with connections. I don't know. We have to wait a little bit. Proszę Państwa, w czasie sesji także
Ladies and gentlemen, today in this session we will have the president of the Agency for HTA and Tariffs, Roman Topur-Mądry, who will speak about the systemic tasks of the agency concerns HTA in the European Union, and I will close the session. I will sum up the systemic changes in reimbursement in Poland in 2020.
We have some problems with connections. Marion, could you connect again, maybe it will be much easier because some... Bardzo Państwa przepraszam, łączyliśmy się ale było wszystko ok, teraz mamy jakieś problemy. Tak, teraz już słychać? Ok, Marion, can you start? It should be okay now.
Okay, we just... Oh, so
yeah.
Good morning and thank you for the presentation today. I've been asked to give you looking at and how we are using information resources to drive improvements in policy and patient care. So what I will cover this morning is just an overview of medicines in healthcare, and then focus down in giving you 2 examples of our activity in Scotland to illustrate how we've been using medicines data over the last 10 years, and including obviously through the pandemic, to support our health system in Scotland. So globally, and certainly for this audience, you'll be very well aware that medicines are a large proportion of the cost in any healthcare system, with up to 30% of that cost in low to medium income countries. And they are not without harm. And just for introduction, I'm based in Scotland, part of the United Kingdom, and we have a population of just about 5.5 million people and a medicines budget of about 1.8 billion per annum, of which about 60% of that is in our primary care community health system. If we think about medicines and medicines harm, then this is just an infographic that we use frequently with our policy and wider stakeholder community, just to demonstrate the importance of safe and effective use of medicines. So on your left-hand side is our primary healthcare system, and from the data that we have, we can estimate that 1 in 5 adults in Scotland will be on more than 5 medicines, and that contributes to over 100 million prescription items per annum. But with that comes a degree of potential harm. So down at the bottom, we estimate that about 60,000 patients per annum will present to our hospitals as a consequence of some of the medicines that they are using, and the most typical ones are illustrated there. If we look to the right-hand side of the slide, then this is our story in our hospital acute care setting, where we estimate that in a year about 435,000 inpatient prescriptions will be written in our 500-bed acute hospital, and that will attribute to over 2 million administrations in a hospital of that size. And again, some of that is not without harm, with an estimate of about 15,000 potential adverse events and 280 potentially preventable deaths. So that's just some of the numbers that we use with the data that we have. And I'm sure you could relate that to your own countries, but it's a really useful infographic when you're dealing with broad stakeholders. So what shapes our medicines policy and in my country is really 2 dimensions. So it's the broad health dimension, and most recently we have our recovery plan moving beyond the pandemic. But in advance of that, we had a joint health policy looking at and described as realistic medicine, which is really starting to have the conversation with patients around when do you start and stop medicines. And on the right-hand side, to complement that broader health policy, we have our own pharmaceutical policy that focuses both on specifically looking at things like access to medicines, medicines, but also much more broadly looking at pharmaceutical care and pharmaceutical care in the context of our wider health policy. So that policy framework is really important if you're trying to get traction to drive change. And this is just a range of different medicines policies that we have been working with over the last 10 years. And I've been asked to speak to you about two of those, which are highlighted in green. So I'm going to focus on high-risk medicines and how we've driven and supported that policy direction and improved safety for patients in our primary care setting with our medicines capabilities. And then I'm going to talk to you about cancer medicines and how we're using our data to support better understanding of the use of cancer medicines in our health system. But there are a range of other agendas there, including most recently, obviously, the work that we've been doing with COVID, and I'll touch on that at the end. So starting with high-risk medicines, this has been a journey really over the last 6 to 8 years, thinking about how can we reduce the exposure to patients and better safe use of high-risk medicines, and specifically through a data-driven programme. So we've generated some evidence. We started in our country documenting what our primary care capability was in respect to medicine. So we published a resource called the Scottish National Prescribing Information System. We then have provided some tools and some text mining methods and documented that so that people can come and work with that data for lots of different reasons with the appropriate governance. And then we did a 10-year look back of the first 10 years of working with that national medicines primary care data set. And I'm going to focus on our illustration around high risk medicines this morning. So if I take you to the health context for this, really we were using both the much broader global agenda here, so the WHO Medication Without Harm document is a key driver internationally. We looked then within our realistic medicines health policy to look to see we wanted to drive a more informed conversation with clinicians and patients around the choice of medicines and the continuation of medicines. And then we added into that, strategically beyond the policy, a programme of work across the nation that we labelled the Scottish Patient Safety Programme, which had multiple dimensions, one of which was a medicines strand. So that was the context under which we were operating to try and drive down high-risk medicines use. And we underpin that, firstly, and informed by a research agenda. So in this example, I'm going to show how the research has informed practice, policy, and then implementation. So we started in this case with a funded research programme, collaborative within Scotland, looking at how could we use routine data to better drive improvements in patient care across our health care community setting. And the background to this was again looking at the evidence, recognising that high risk prescribing can do harm. I've illustrated that in a previous infograph. That our Cochrane review database is basically calling for better evidence around how data and feedback can provide improvements in care, and to do that in a much more robust manner. So we read the evidence and built on that as we moved forward. And from that, with the collaborative NHS and university teams, we then produced a behavioural change in complex intervention, but something potentially that could be done at scale. So we looked at behaviour, we looked at action processing, and importantly, as we thought about that intervention, we engaged with that clinical users of that potential intervention. So we worked with our general practitioners and our pharmacists to do a development pieces that we would use within that intervention. And we constrained ourselves, recognising that frontline clinicians were very, very busy, to being able to think about a persuasive communication that was limited to 1 page of A4. So we took that theory, we worked with the clinical community to identify a series of 6 indicators that we knew we could collect and monitor within our national prescribing data set and generate feedback on a quarterly basis to this community. And these are all the medicines that are highlighted in the infograph that can cause significant harm. So we agreed that in a consensus process with our clinical community. We then deployed a cluster randomised study to look at both basically a control arm, which was arm 1. Arm 2 was just providing the data feedback on a quarterly basis for those measurements that we'd agreed with the community. And the third arm was actually adding in this persuasive behavioural change communication to them. So we ran that over a 12-month period with a group of general practices across Scotland, and we ended up with about 55 to 60,000 individuals exposed to this intervention across those practices. And what you can see here, and there's a publication if you want to read more, is that if you look at arms 2 and 3, then there has been a reduction in an already declining incidence of high-risk medicines prescribing as we calculated that in our studies. So things are happening in the content, in the environment anyway. It was improving, but this intervention allowed that to improve more rapidly. And the consequence of that was a 12 to 14% reduction in high-risk prescribing among our practices with these intervention arms, with quite a simple educational intervention that we could generate at scale and produce relatively automatically. So that's the research. How did we drive that into policy? So what we looked at, and because we had the stakeholders with us from the start, we started to then say, well, what's the route to translation into practice? And in Scotland, we have a resource called our National Therapeutic Indicators, which goes out on an annual basis to all 9,500 general practices in Scotland. And what we did is we took the indicators within our research programme and built them into this annual resource programme that is used by the clinical teams in the practices to actually drive improvement. And we also have an evolving polypharmacy guidance agenda, and we built those indicators into that. So it's coming back to the policy piece to support translation. And with that, what we have is an indicator dashboard. So this is just an illustration of along the x-axis, all our health system boards, so our local system within Scotland broken down, and what is happening over a period of time in the context of a particular indicator, which we call the triple whammy, which was one of the indicators within our research programme, to allow that feedback to go back to the community to see that they are improving all the time in the consequence of reducing their high-risk prescribing. And that is sustained and ongoing now. And the other thing, that's a non-interactive feedback to them, but we have also generated an interactive platform so that within that primary care setting, individuals can select their practice on the left-hand side, and then they can look to decide how they want to compare that with either their peers locally, nationally, etc. So it becomes a much more interactive platform and makes that data much more live for that community. So that's how we drove that practice forward. And in addition, we took the opportunity to not just work with the general practice setting where predominantly medically orientated practitioners are based, but we also extended this programme into our community pharmacy setting in Scotland. And we use a similar approach, not doing a clinical trial. We drove an improvement programme. This time we started with a small number of 29 pharmacies. We worked through an improvement programme. We created a series of what we call care bundles, which are activities that the pharmacy staff can do with their patients in the community pharmacy. And we drove that through and tested that in that setting and that context. And that's now been picked up again by policy and is now a paid service across our 1,257 community pharmacies in Scotland. And through the publication route and other networks, we've been able to drive and support that happening elsewhere, in this case for this programme in New Zealand. So that's our example in respect to using data through a system of research and policy and service integration to drive down high-risk medicines prescribing across that primary care setting. The second example I've been asked to share with you today is looking more at our hospital care and our new cancer medicines, and looking to explore again how we can use our medicines data to better understand what benefit and or harm we may be doing with these medicines in our population. So if I take you then again to the health system and policy context, and I can't emphasise too much around how it's important to get that broad stakeholder community engaged with you. So in this case, this was cancer, particular clinical condition that we were looking for. So we were influencing and getting traction within our cancer policy, Beating Cancer Ambition and Action. We were looking also to shape and use our digital evolving strategies to help us to work with the data, the cancer medicines data. And that was our first phase. And our second phase, which we continue to drive through now, is looking then to our recovery plans within the health system and how importantly cancer services have been impacted by the pandemic, and how our medicines data can help to support understanding of what that has been happening through that pandemic. So that's the policy context in our country. If I then just remind you all, and it's given the audience is not necessarily needed, but with all new medicines coming to the market, then we have a strong clinical trial evidence base normally, but really we're not so sure about what happens as we come into a much broader real world setting. So the regulatory system allows us to come through the licensing process, EMA, and for us now the MHRA. It comes down to our health technology assessment organisation called the Scottish Medicines Consortium in Scotland, and in England NICE. And then it comes down and cascades down as those decisions are made into our regional and local health system formularies through our drug and therapeutics committees. And it was that forum locally and regionally that was asking to say, well, how, as we use these medicines, what does that mean for our patients in our setting? So if I'm a clinician, how do I know how best to select patients? What may be some of the long-term issues with these medicines coming onto the market? If I'm the patient, really, what kind of side effects may I be likely to experience, and or what treatment might best suit me? And from the health system perspective, strategically, what's the value from those medicines? What does it add? And what's the service implications for that? So those were all the types of questions that are being asked as new medicines, and in this case cancer medicines, are coming into the system. And it's important to think about that as you drive forward programmes. Who are your stakeholders? So what our government did was they funded a programme of work called CMOP, the Cancer Medicines Outcome Programme. And it focused on two elements, and I'm going to talk to you today about the clinical effectiveness side of this. How can we use our routine data that is generated through our health system to understand better who's getting these medicines and what impact they're having, be that harm or benefit. And a second arm, which I won't go into today, was also very much focused on what impact was that having on patients' quality of life. So not just the clinical biomarkers, but also the quality of life. And we've got an evolving programme in that area for cancer. So I'm going to give you an illustration from this programme of what one of the first things that our clinicians called for and for our strategy stakeholders was, how were we using these medicines? How in the context of the clinical trial evidence, who was getting these medicines in our population in Scotland? So we picked a particular group of medicines and a particular cancer. In this case, it was metastatic prostate cancer. Two particular medicines that had come through our HTA process, and we wanted to look at how could we capture this data routinely within the system. We wanted to look at how many of those patients who had had treatment would have been trial eligible, and what was the outcome of those patients, be they overall or those that would have met the trial eligibility criteria. So we used a standard methodology which allowed us, sorry, there should be text in here. It's a cohort study looking at a period from 2012 to 2017, and we used traditional pharmacoepi analysis techniques. What we used was, this was the data that was available to us, routine data that we record linked through the use of an individual number at the centre here. It's a CHI number, yep, patient identifier. So every patient in our health system has an identifier that allows us to link their chemotherapy data to their hospital activity records and to a set of other data sets as well. So this programme was linking that routine data to identify patients and to then understand their characteristics and outcome. And this is just an illustration of the data sets that we use that are available to us in our health system. We use them to identify the patients, to characterise those patients as best as we could with the routine data, and then to understand both the exposure in respect to the medicines and also the outcomes in that context. And in this case, we looked at a subset of the Scottish population in the west of Scotland, which covers about 1.2 million population coverage. And we looked at these two medicines which can be used either pre or post chemotherapy. So we were able to capture the numbers, patients, we're able to understand the follow-up period and start to look at, I've just illustrated a couple of dynamics there, but you see that the median age is over 70, and often in a clinical trial setting that would not be typical of a recruitment for inclusion criteria into clinical trial. So we looked at the key clinical trials for prostatic cancer in the use of these medicines and identified the inclusion and exclusion criteria for these trials. We then looked to see with our routine data, could we capture those criteria, and then could we then look at what the impact of that was. And with our routine data, on average, we were able to capture around 2/3 of the inclusion criteria and half of the exclusion criteria. So the data is not as rich as it is in a clinical trial setting, but we were able to capture a significant amount of those criteria. And this was what we found, is that the blue bars are all our patients and the green bars are those patients in our population who would have been eligible, given the information that we had, to be included in the clinical trial. So for pre-chemotherapy with these drugs, about 1/3 of the patients would have been eligible, and post-chemotherapy, approximately half of them. So we are using these medicines out with the clinical trial original evidence base. So what does that mean for patient outcomes? So in this table, on the second column, you can see what was the overall survival, the median overall survival for our cohort of patients overall. And the second column demonstrates that in comparison to the pivotal clinical trials. So obviously performing not as well as the clinical trials. But if we then looked at our subgroup of the patients who were eligible, potentially given the criteria that we had, then you could see that that median overall survival was definitely better in 3 of the 4. Our fourth era enzalutamide pre-chemo, we didn't have sufficient patients, is probably the main issue there. So you can see there is a differential there given our population and our characteristics, but getting much closer to the pivotal trials with those that would have been trial eligible. So if you want to read more again about the work that we've done with this particular study, then it's available and published. So in the conclusion slide, again, apologies, this hasn't come through, but our conclusion for this study really is that it's important to understand impact in your healthcare system. It's really important to recognise how useful your routine data is to actually generate this data. And for us, really, we were trying to prove that we could do this through routine record linkage as opposed to by doing the traditional clinical audit, high resource intensive review of clinical notes. And with that, we've then been successful in able to secure ongoing funding as part of our pandemic recovery policy piece to continue to build and scale this up across Scotland so that we can routinely look at all medicines across Scotland that have been prescribed for cancer care. And again, if you'd like to read a little bit more about that, then we've written a paper that just really of our experience of the first 4 or 5 years of working with these data, working with our stakeholders, feeding back and understanding better the harm and benefit from these medicines as from our routine data systems. So finally, to finish off, I'll just come back to the medicines programmes that we have been involved in over the last 10 years. And I've given you a couple of references there. So again, if there's other areas that you're particularly interested, if it's around the antimicrobial stewardship area, then we've got a lot of work done in that area, particularly again building on an intelligence platform using our data to drive improvement in stewardship at a local level. And also through COVID, we're in the midst of this, as are all other countries at the moment. But we now have a stream of data coming in from our hospitals, which is at a patient level. We've had a historical hospital level cost and volume data set for a number of years, but we've now got patient level data. So under the COVID umbrella, we're starting to look at those medicines that have been shown through clinical trials to be effective for the management of COVID. We're monitoring those in our routine health system now. So dexamethasone, bendivir, etc. that are being used in our hospitals, we're starting to look at, just as we've done with cancer and with primary care medicines data, start to use that intelligence to understand how those treatments are being used and what impact they are having. The other thing we put up quite rapidly was impact on routine care of medicines. So we have a dashboard publicly available demonstrating for mental health medicines and cardiovascular medicines what has been happening to the uptake of those medicines over the time period of the pandemic, and that's refreshed on a monthly basis. Those are probably the main things. A new area that we're trying to again use our medicines data for is to look at the risks and harm from sodium valproate as a response to all the regulatory changes, and a UK Cumberledge report at the moment, but again through routine data. So thank you. I think, yep, that's me finished. So thank you very much for your attention this morning, and I hope it's been helpful just to have the experience and listen to the experience of what we've been doing in Scotland with our key. Thank you.
Thank you very much, Marion, for your lecture. The questions and discussion is the end of the session. I hope so that you can stay with us a little longer. Thank you very much. Proszę Państwa, zapraszam Państwa na następny.
Ladies and gentlemen, let me introduce the next presentation, which will be given to you by the President of the Agency for HTA and Tariffs, Mr. Roman Topór-Mądry, and the Director of the President's Office, Kamila Malinowska. In this presentation, we will learn about the systemic tasks of the HTA agency, which changed during the COVID-19 pandemic, and we will also get a perspective on HTA in the European Union. I hope that you will hear something new also at the EU level. Ladies and gentlemen, please enjoy the next presentation.
Unfortunately, we are yet again experiencing a technical problem. Can you hear us? I can hear you very well. Unfortunately, we do not have a good audio reception.
The audio quality is not good enough to provide interpretation.
Te podstawowe rzeczy dotyczące i działań w zakresie
we'll be discussing the main challenges faced by the agency, and also and I will present various special projects that the agency has been engaged in. We'll also refer to the latest challenge of the agency, that is the assessment of high clinical benefit drugs and high innovative drugs, and that will be presented by Director Kamila Malinowska. I am not sure if this lecture
to chyba nie jest ten wykład.
That might not be the presentation I intended to show you.
Ten poprawny.
If you could set up the correct slides, that would be perfect. We are right now experiencing some technical challenges. We hope that we'll be able to come back to you very soon. I hope that we'll be able to start the presentation real soon. We already have the slides visible. I don't know if you can hear us.
O, już jest poprawna.
Now we have the slides we wanted to see. Perfect.
Także, szanowni państwo.
So, ladies and gentlemen,
oczywiście agencja
the agency, with every year, is a ghost of your symposium, So we have been here with you for the 16th year. That's the 16th year of our existence. Since the first years when we started to deal with drugs, with medicines, we have the scope of our tasks has grown. Last year, we have added the technologies in the medical funds, that is the high clinical benefits drugs and high innovative drugs. The years to come also are associated with new challenges of various analyses associated with the amended Act on Reimbursement, including rare diseases. So when we look at all of this, all of the tasks that the agency is facing, we are still waiting for the slides to load.
To oczywiście proszę zobaczyć, że problemów, które rozważać,
that we should address include both efficacy, economic effectiveness, the cost of treatment, budget impact analysis, and that applies not only to drugs and medical devices, but also to nutritional foodstuffs. They have to take into account evidence from RCTs and real-world evidence. We have to assess also what unmet needs there are. We have to take into account guidelines of clinical practice. We look at the system from the point of view of the tasks for the healthcare professionals and also from the perspective of the patient.
I również jakie są zadania pacjenta, który jest aktywnym podmiotem
with the assumption that the patient is an active actor in the treatment process.
Różne punkty, które
of course, we have to take into account various endpoints, which are quite a challenge when it comes to interpretation. So we have survival surrogates, the quality of life, and of course we have the data element. Collecting data, synthesizing and analyzing data. This is all what needs to be reigned by a modern high-end analysis. So it's still a process that is ongoing. On this slide, you can see the core tasks faced by the agency. Obviously, we also have additional elements, which I haven't mentioned, some related to COVID and to the standard cost accounting and guidelines. And I will discuss in detail a few of them. Most of all, the tasks related to the pandemic. The subject of this symposium is related to the pandemic. I don't know if you follow our website, how many elements and tasks related to analysis in the pandemic we have already performed. The core elements are obviously the diagnostic and therapeutic recommendations. We've already published 131 of those. We are working with 38 experts in various fields to publish those recommendations. We have carried out over 30 different reviews. We have created several tools. I don't know if you've had the chance to use them. Among others, we extract data from randomized trials. We also have other databases that can be really useful.
Są inne też
We also
działania
have
związane
different actions taken
z COVID-em
that are related to COVID, for example, related
ale
to
również
tariff setting,
razem z Agencją Badań Medycznych
and along with the
aktualizujemy
Agency for Medical Research, we are running
czwartej fali.
updates every fortnight with regard to the fourth COVID wave, and we provide that data to the Minister of Health. And of course, we have prognostic analyses that we carry out along with the Washington University.
Proszę Państwa, to bardzo dużo zachęcam do
there is a lot more. I encourage you wholeheartedly to acquaint yourself with what we've already gone through as an agency. We know that there is a multitude of those publications. Some of them are of poor quality. Obviously, the top journals guarantee top quality, but not all publications are published in top journals.
Badania dotyczą jednego.
We have also data on one or two trials. We don't know about the quality of data sometimes. A big task of the agency are creating guidelines. We have prepared and published guidelines for the assessment of medical devices. That was the result of lengthy works. We have engaged 70 experts in this task. About 1/3 of them were very active in this process of developing guidelines, and I would like to thank those experts for this activity. We know that both with guidelines and standardization, this scope of analysis needs to be very precisely defined, and I hope that these guidelines will meet that task, meet that objective. So this is this first element when it comes to the major element of guidelines, that they need to be universally accepted. We have also published more than 10 guidelines. This year, we are also finalizing the process of publishing a consensus with regard to oncology, so cancer treatment guidelines. We are finalizing works on that as well. We are experiencing some technical problems and not everything is audible. UNETA is a huge project which finalized this year. As part of this European cooperation of various agencies, we have worked together to prepare reports together. We have discussed issues related to the quality. Our agency was an active player in those works. We were also reviewers and co-authors of various aspects of the guidelines. There were numerous actions taken as part of this initiative. You can see them on the slides. So we wanted to be an actual report, offer or co-author of the report to show our expertise and to try to implement various conclusions and various experiences related to participation in this major project. Obviously, we know that joining in on the knowledge, on the expertise is always a guarantee of increasing the quality that we are dealing with.
Na poziomie europejskim z wieloma partnerami wypracowywania
taking up efforts with multiple European partners is time-consuming, but it's definitely worthwhile. So we can wonder whether this process of putting the effort in is equal for different partners. What I mean is whether all the players have the same objective. Because we know that generally the new drugs that are authorized to the market should improve the existing quality and should reduce the costs of treatment, and also should address the unmet needs. We have also been working on changing the scope of the PICO. We have been working on the time consuming of the process. This was done with the participation of many partners on the European level. And another element, which might be the most important aspect with regard to this cooperation, that is the joint clinical assessment. So joint clinical assessment of one technology throughout all countries that participate. We have been a part of that since the very beginning. We have given our commentary on the numerous versions of this regulation. The general idea is that there is one joint clinical assessment, and then the appraisal and assessment of the economic analysis, of the budget impact analysis, remains the domain of specific countries. Currently, this is on a voluntary basis. The translators are still experiencing problems with the audio. So the rules for the joint assessment still are not very precise. And therefore, we are left with some questions about whether the regulation is solving the most urgent problems. On the one hand, yes, because it can standardize the process of the clinical analysis assessment and lead to the development of a common methodology. However, it most definitely does not help in solving the problems that need to be addressed. That is, better access to patients, reasonable pricing,
wdrażania do fundacyjnych, kwestia cenowych,
so the pricing aspects,
negocjacji,
and negotiations, getting rid of inequalities, and we also have doubts about whether the quality of the evidence will be better.
However,
when it comes to some of the aspects, you can see I put question marks. We know that to date we haven't finalized the process, and this methodology is being developed and will continue to be developed. That's why the question marks on the slide can be seen, because this is where we can actually reach our objective. So at the end we can wonder about what the assessment on the European Union, the audio is out. Other aspects which I wanted to highlight with regard to the agency's work this year and last year was the standard cost accounting, was the introduction of a uniform system for accounts in all hospitals, so that we can learn the personal costs in different hospitals, to learn what the payroll for the healthcare professionals are, to allow standardization. Our last pilot project shows that over 70% of hospitals run the standard cost accounting procedures correctly. So we can see that there is still a lot of room for improvement.
Ladies and gentlemen, the quality of the sound is very poor. We do not hear the speaker well. This is also a remark for you to use an external microphone and provide a stable internet connection. That way it can be interpreted.
Gdzie można będzie i zarządzać kosztami, i przychodami, i wyliczać koszty procedury, porównywać na marketingu razem z innymi, do innych świadczeniodawców, co może też pomóc.
We're getting about half of the words the speaker is saying.
We have also been developing our IT tools, which are related to drug technologies. So we have the emergency access to drug technology database. You can, and also a database for high clinical benefit drugs and high innovative drugs. All that is included in separate databases. And of course, we have a separate application for tariff setting and a number of our internal applications which facilitate our work. So this is something which should modify the way we use and understand various elements of our work. You can see our various international involvement on the slide, not only UNETA, but also FAB, Global Burden of Disease, and numerous other initiatives. These actions help us, first of all, participate in various processes and take active participation in actions, also in the European Commission. We have a problem with the slides. I will now give the floor to Director Kamila Malinowska, who will tell us more about the project of the medical fund and about the two types of technologies, high clinical benefit drugs and high innovativeness drugs. Thank you. Ladies and gentlemen, on my part, I would like to present to you another task that is faced, what the agency was faced during the pandemic, and which we continue to carry out. Of the tasks that you can see on the slides, well, you can see that there are a lot of them. Two products of those tasks was something that you could already observe in February this year. And the last task that we've carried out was the list of high clinical benefits drugs, which was published at the end of August. Those two tasks, those two lists, which are very similar actually to one another and might have similar names, actually have several differences. First of all, when it comes to high innovativeness drugs, which we call the TLI list, is about drug technologies which received marketing authorization in the central procedure at the beginning of 2020. On the 26th of July 2020, and we need to prepare such a list at least once a year. And when it comes to the high clinical benefits drugs, that list is about technologies which were registered as part of the central procedure between the 1st of January 2017 until the end of December 2020. And this is a task which we were to carry out only once, and the deadline was August this year, and that's when we published the list. Another difference between the two lists is that the TLI, so the innovativeness drugs, is only about cancer indications and treatments used in rare diseases. And with regard to the high clinical benefits drugs, so the TLK list, there were no limitations when it comes to indications of the specific drug technologies. One common element which both lists have in common is that no drugs technologies could have been reimbursed in Poland before. Although there is a difference in the case of the TLA list, there is the cutoff point is submitting a motion on establishing a statutory price and reimbursement. The elements that need to be taken into account to be entered into this list is we need to see the indicators of effectiveness of the treatment, the anticipated health benefits, the detailed conditions for use, and the target population. It is important because in the case of health technologies included in the TLI list are to be technologies that will be very strictly monitored over time when they are reimbursed and used in actual clinical practice. The Act also indicated what elements should be taken into account during the assessment, and we have clear guidelines that each time we should assess the strength of intervention, the quality of the evidence, the unmet health need, the size of the target population, and the health priorities. So, every technology needs to be analyzed with regard to those aspects. All those aspects are included in the specific analysis, and that data is available on the website of our agency. We have provided a separate section about each aspect, which can be found on our website. In the first TLI list, so the innovative drugs list that we published in February, we have presented 11 different drug technologies, and in the other stages, the Transparency Council has recommended 4 drugs to be included at the list of the Ministry of Health, and on the final list, 5 different drug technologies were placed. For each of those technologies, the agency has prepared very detailed assessment criteria and data on effectiveness and efficacy, and specific criteria for the target population, because in the subsequent stages it will be necessary to assess their actual effectiveness in clinical practice. The list that was published at the end of August this year, that is the list of high clinical benefit drugs, is made up of 35 drug technologies, which received marketing authorization in the aforementioned period between 2017 and the end of 2020. 951 technologies received marketing authorization, and the agency has already identified that 577 already receive some form of reimbursement, and therefore they could not be assessed as part of this list. So 374 drugs were actually taken into account during the analysis. It was a very important systemic task from our perspective, which allowed us to look back at what the situation is of a specific compound, a specific molecule in the reimbursement. Of those that we assessed, we could see that in the past the agency would assess technologies, drug technologies which were original, and for some reason they were not covered by reimbursement. And this exercise allowed us to see that for part of those technologies, the clinical situation and the financial situation could change dramatically. For example, generic decisions generic technologies were introduced, which shed a completely different light on the original drugs. The financial questions obviously was not the criterion which we took into account when creating this list of high clinical benefit drugs. However, without doubt, this is information which the criteria we used could show that over time the situation of a specific molecule could have changed. The list of the high clinical benefits drugs is just the first stage of the process of reimbursement coverage for those drugs. Because after the list was created, it was passed on to the Ministry of Health, where then they are subjected to the opinion of the national consultants, of the Transparency Council, and also of patient organizations. On the basis of all that, the process of talks with marketing authorization holders will commence. An important systemic task that the agency is running in the background, it might not be visible, but it's something that we have to get ready for. It's the question of taking up the task of assessing effectiveness in real time. This is a very ambitious task that we'd like to take on. We'd see the activity of specific drugs and how they work in clinical practice. The COVID pandemic has shown us that this is very important. We are now working with a team of experts on preparing a questionnaire that can be used. When a patient is covered by a specific intervention, we'd like the patients to provide us with data as soon as possible, and we need to run registries as soon as possible. And 90 days before the reimbursement period ends for a high innovativeness drug, we could publish a report on the actual effectiveness of the drug in comparison to the alternative treatments in that indication. This will be an interesting observation
ostatecznie zostanie objęte finansowaniem ze środków.
and will allow us to lead to a situation where we know which intervention in the end will receive reimbursement. I would like to indicate that our agency is as old as this symposium, 16 years, and I hope that next year we will also be able to take part in the symposium. Thank you very much. I hope that you will stay with us for the discussion. In 25 minutes, we also have Minister Krzysztof Wanda and Minister Marcin Czech, and I hope you will be able to join the discussion. Unfortunately, Minister Miłkowski will not be able to join us because he was summoned for some governmental meeting. Thank you for this presentation, and I would like to invite you to a presentation that I am going to give as a summary of what the system did in the last year.
In my presentation, I will refer also to what has been said, because at our symposiums, we get the opportunity to look at changes across the globe and in Poland. Ladies and gentlemen, from the perspective of thinking about drug policies at the national level, we look at a couple of points which have emerged in recent years. So the national drug policy from 2020, which covers the period of also 2021. We can see that in 2018 and 2019 we've had some new legislation, some regulations on rare diseases, and we can see that Poland has started thinking on including new and innovative drug technologies in our policies and thinking about how to fund them, how to maximize the health benefits and outcomes we want to receive. The medical fund is an example of a legislative act which was issued last year and covers changes happening this year. I think that these are very closely followed by all the stakeholders of the healthcare system in Poland. And we can see that also across the globe, because we can see that Poland follows suit. Things like this are happening also across the globe. What is important about the national drug policy, something I would like to draw attention to, is introducing more and more new molecules into the system. I think it's a challenge for all healthcare systems because it is connected with costs. And it is also important to think about what happens after reimbursement, so how to measure health outcomes in the system. And that is why the Rare Diseases Plan expands the scope of thinking about how we want to go about reimbursement in Poland. I recommend that you read this document because it outlines the developments as concerns the creation of expert centers for rare diseases, digitization, creating passports for patients with rare diseases, enhancing communication and exchange of information. What is important is that this plan focuses on increasing access of patients and lowering any fees they have to pay. So also reducing the burden on patients, but also their families in case of treating their symptoms. In the case of new rare diseases, this is about 200-300 substances that we can cover with reimbursement. And this is a challenge for all payers. That's why the medical fund is a response to these challenges. And on the other hand, something which you cannot see on the surface and is difficult to monitor is how access to reimbursed drugs improved or deteriorated. Not just the drugs used in closed treatment, but also prescription drugs, which we can see that in recent years have been falling behind the drugs used in closed systems. That means we are introducing fewer prescription drugs than in the other area. especially as concerns civilization diseases. From the perspective of the entire national system, we must know that in 2020 we introduced a reimbursement act, and this was one collective document which was supposed to regulate all reimbursement-related issues. From 2019, or actually in practice from 2020, we have a new legislative act on the medical fund which outlines new paths for reimbursement. If I were to sum this up, I would say we have two paths: regular reimbursement and conditional reimbursement, and the second one is the medical fund. What is also important in 2020 and 2021, Poland has seen some changes concerning the total reimbursement budget and its definition. In 2020, the total reimbursement fund was expanded to include drugs for patients over 75 and used by women during pregnancy. What does this mean? What are the aspects related to this? We must be aware that when we look at this through the perspective of the National Drug Policy document, calling for an increase in new drugs being introduced and increasing their innovativeness, we must bear in mind that all global systems strive towards optimization of the healthcare system within the available budget. And here we believe that in Poland we are approaching a certain border, a certain wall, because we have experienced recently a drop in spending on drugs, which has been elevated in 2020. The reimbursement budget was expanded to cover drugs for those over 75 and used during pregnancy, which was an additional cost of about a billion Polish zlotys. Now, why were these drugs introduced to the reimbursement fund? Well, we have COVID-19 and the pandemic, and due to that, we need to finance therapies in hospitals. We have an additional burden of care over patients who have survived COVID-19. We must ask ourselves the question, where are we headed? So the Reimbursement Act and its provisions pose some questions about the future of reimbursement in Poland. On the other hand, we must look whether we are actually maximizing the healthcare benefits. We are collecting data not just on reimbursement drugs, but also information which is available in IT systems on over-the-counter drugs. We had an example from Scotland. So we are also thinking about how to monitor polypharmacy, how to ensure compliance of patients during treatment. As concerns everyday treatment. I think that Scotland is a very interesting country, but other countries are also worth noting. They're starting to introduce a dashboard, so interactive screens which show results of patients, individual patient accounts. And this seems to be becoming a realistic tool for decision makers, but also for physicians, for doctors in everyday clinical practice. And yet, on the other hand, if we look at these two paths, so regular reimbursement and the medical fund reimbursement, we've already heard in previous presentations that we have the highly innovative drug pathway and the high clinical benefits pathway. And these are quite different, but the goal, the grounds for the whole Medical Fund Act is to increase access, facilitate, accelerate access, and on the other hand, measurement of the actual outcomes. That's why we're using registers. Under this new path, we resigned from a full assessment. I think that this will have consequences. We can also already see them now. The highly innovative drug lists, we have 5 innovative technologies which have a chance of entering the market, and this is where the first concern emerges. 22 is nearing on its end. And the chances of spending all that we have, the 75 billion, is becoming slimmer and slimmer. I think that this is important for decision makers, but also for the competent entities, because the negotiations have been shortened to 30 days, which is something new. This is due to the fact that in-depth analyses, more in-depth analyses are not necessary anymore. We are aware that these reports which we will be receiving will be expanded, made more detailed in the future, because they will include experience from this year. We underline the conditionality of introducing highly innovative technologies to the market. It has been said that after 1.5 years, the clinical effects will be assessed to determine whether there has been an improvement in the patients as compared with the present standard of treatment. We are already talking about another document, a comparative analysis. I hope that it will soon be made publicly available. Today, we are on the threshold of thinking on how to actually collect data from drug programs, from treatment programs. We are talking about close treatment here. So how to collect the data, which in the SNPT process were limited for several reasons. So we approach the question, and certain concerns for the future. Is 1.5 years enough to assess the health effects of the technologies used, especially in rare diseases? While rare diseases are usually chronic diseases, leading to long-term disability and a worse outlook on survival. Ladies and gentlemen, let me point to the fact that the Medical Fund Act points out that highly innovative technologies is a way of catching up, of making up for all the delays and irregularities until now. We selected 35 drug therapies which are limited, well, in our opinion, to high unmet medical needs. And on this account, we approached the question, how did we select these technologies? On what grounds have we done this? Do they actually take account of all the gaps, of all the deficiencies in patient treatment paths? What I want to show you in this slide are the criteria of the assessment. So they're present in all the assessments, but this is what the agency looked at in the medical fund pathway. You can see the criteria are actually identical, but the question is about the size of the population assessed by the agency. Now, this is difficult because if we speak of high innovativeness, then the Act focuses mainly on clinical assessment, to a lesser degree on the economical analysis or budget impact analysis, which was to form the basis of the discussion in the economical committee. So we look at all the aspects, unmet health needs, clinical analysis, economical analysis, budget impact analysis. This enables a broader analysis of the data and enables to prepare for negotiations, also to decision makers. Let me just go back because what I want to show you is that high clinical benefit is the same pathway as regular reimbursement. The new thing is the comparative analysis report, which might raise concerns whether this short period of 1.5 years is enough to confirm the beneficial health outcomes, and whether this is a sufficient basis for introducing these new drug therapies. When we look at the system, we cannot disregard the broader context of already reimbursed drugs. We must state clearly that starting from 2015 through changing governments and ministers of health, regularly introduced new drugs, and we are very thankful for that because we can see that we are catching up in some areas as concerns certain diseases, especially in oncology. This is visible. What raises questions is the price levels and maintaining the situation in the market in the long run. And this concerns the solutions put forward in the revision of the Reimbursement Act. What we can see in Poland in drug reimbursement are new technologies introduced to drug programs. We have more than 100 programs which are being expanded continuously by adding new molecules or new indications. On the other hand, we can see the need for improving our thinking about open treatment because we have fewer drugs introduced there while civilization diseases like diabetes or asthma. We can see that introducing new drugs leads to improvements. In the case of, and the treatment is not balanced when we compare this with new oncological drugs and unmet health needs. When we look at the statistical figures, what seems key to assessing health technologies, we can see that 5 out of 45 drugs registered as drugs used in rare diseases or oncological, that means 11%, which were assessed since 2017, and 8%, so 30 out of 379 were introduced to the list of drugs with high clinical value. So you can see that the rest of the technologies were assessed while taking into account the impact on the budget. So the question is, we will use the potential of horizon scanning, which we are performing for the medical fund. This was not present in Poland until now. So the question is whether unmet health needs, whether this issue of budget analysis should not be preceded by a dialogue with a broader group of clinicians, of experts. As you know, the list of high clinical value drugs is being consulted at the moment. We are collecting opinions from different social groups and stakeholders to create the final list of the Ministry of Health, and that will be the basis for reimbursement applications. Ladies and gentlemen, so horizon scanning, as I mentioned, the answer to this question that we don't know is whether these technologies assessed under this pathway have a chance of regular reimbursement. We don't know how these therapies are treated, whether these are drugs of high clinical value or maybe rather this list will have to be verified under the regular reimbursement pathway in line with HTA principles. In 2020, you've seen a slight drop in reimbursement applications. So the question is, how will the medical fund operate in 2021, 2022 and 2023? When we look at disease severity and clinical unmet needs, we have to answer the question how to define this. So I've summed this up in this slide, all the approaches, how FDA or the EMA approaches this upon drug registration, but also some countries select their own definitions of a clinical unmet need, so the severity of the disease, the perspectives of the patient, not just overall survival or disease burden. Some definitions also include the strong adverse effect on the quality of life. Very frequently, what is included in this definition is the number of available therapies. So the lack of an alternative therapy, so only treating symptoms, is also an important element of this definition, and then it is important to determine how effective these available or accessible therapies are. This is what we can see in the system what the patients can experience within their groups. And this will lead to the creation of maps of clinical needs, which will form the basis for decision making, because these criteria will be replaced by a map of needs and recommendations for areas we need to assess. This might lead to questions concerning selection principles. What we cannot see in the medical fund is how these drugs have been entered, on what grounds these drugs have been entered into the HTA agency list. What were the reasons for that? We need to ask ourselves about the approach, a more subtle approach, so to say. On the one hand, identifying populations with high clinical unmet needs, because we are departing from this type of thinking where we assume that there is no treatment for certain groups. We are thinking about access and about availabilities and about health outcomes in treating specific diseases. Here I presented the example of female cancers. We can see that survival is still far behind other countries across the globe, and Dali, as shown in the data, shows that endometrial cancer is still an important disease in Poland. We have premature deaths in Poland. We don't have possibilities of early screening or prophylaxis. So in such situations, access to technology is crucial. But if we look at breast cancer, which seems to be a disease well equipped in drug therapies in Poland, there is a gradual increase in diagnosis, identifying patients with slimmer chances of survival.
Gdzie rokowanie tych pacjentów jest co najmniej dwukrotnie niższe niż ogólnej populacji z rakiem piersi. I takie typu analizy dotyczące właśnie ścieżek, nie tylko
exposed to highest risk has chances of survival which are twice lower than the other groups. So in such situations, it is absolutely necessary to introduce changes. If we look at recent developments over the last 2 years, the potential of the fund provides opportunities to hold a realistic dialogue about horizon scanning. Poland can be a partner of Euroscan. Subsequent ministers approached us with conversations about potential participation. The Polish HTA agency is moving towards building IT tools to facilitate access to data and exchanging information. So this is a possibility which is arising, and this has stemmed from the medical fund. What fuels the discussion is how we will assess health outcomes, what the possibilities of analyzing drugs will be, and also the actual expenditure from the medical fund, because you know that the budget size limits reimbursement options also in Poland. Conditional reimbursement under the medical fund entails questions about RDTL and reimbursement. The medical fund simplified the procedure and made it more complex at the same time in the area of decision making. You can see that an analysis of the decisions of the medical fund will be performed at the end of this year and over the next year, and it will provide grounds for discussion on future solutions. And we are already embarking on the discussion of the effectiveness of the system. ABM is participating in this, but also the National Health Fund in cooperation with the Ministry of Health. This makes it possible to assess effectiveness also while involving patients. So the unclear rule of the Polish HTA rule HTA agency here is quite important, but we can see that what has happened recently provides more opportunities for a dialogue with the Ministry of Health as concerns development in the coming year, as concerns oncological and rare diseases. Thank you very much for your attention. And with this last slide of mine, I'd like to thank for your attention and thank you for the previous presentations. And I hand over to Krzysztof Wanda, who will host the discussion following our panel.
Krzysztof, are you with us? Yes, I think I am. I just don't know whether the other speakers are here as well. I can see their windows. So the question to the technical staff. And now I can see everyone. Very good. Krzysztof, the floor is yours. Thank you very much. Hello, Marian. Hello to Minister Czech, to Kamila Marinowska. We have around 25 minutes for our discussion. I was asked to talk solely in Polish, so that's what we are going to do. The first question will be addressed to Marian. Do we have the translation? Can Marian hear us in English? Does she have the translation? Marian, do you have the translation?
I'm hearing you in English just now, yes.
Okay, very good.
Świetnie. Więc pytanie brzmi,
so the question is,
skoro pacjenci,
since patients who are indeed treated in the Scottish system differ from the patients who were included into the registration trials, which are usually RCTs, and since the effects obtained in real life are worse than those achieved in RCTs, then what are the plans of the Scottish Ministry of Health? Do you intend to do something about this information? Do you plan to limit the inclusion criteria for the therapy? Or maybe do you intend to use the fact of treatment of patients outside the registration trials somehow compensated with risk-sharing schemes? Could you comment on that?
So thank you for the question. And it's really so what we do with evidence base, I'm getting quite an echo. What we are doing with the space is to first and foremost feed this information back to our clinical candidate networks, so that at the point of this information is available, clinicians to have a conversation to assist them in best decisions about the treatment of patients. So that is our first focus. The second element then is that as we gather this evidence, then we will work with our national organisation that contracts with companies to then look to have a further conversation around value for money for these products in our patient population. And that may involve risk sharing schemes or other of contractual agreements.
Dziękuję bardzo, Marian. Wydaje mi się, że
thank you. However, it seems that our internet connection with Scotland is pretty poor. I don't know if the translators were able to translate it. Unfortunately, they were not able to translate anything. This was not, we only heard every third word. I don't know if it's a problem on the Polish side or the Scottish side. I hope you are not saving up, you're not being skimpy on prices of internet connection, because something went very wrong.
Także dziękuję bardzo.
So thank you.
Dziękuję bardzo. Dziękuję bardzo. Przechodzimy teraz do szybszej dyskusji pomiędzy głównie panem ministrem Czechem i panią dyrektor Malinowską. Oczywiście, Marian, jeżeli byś chciała się włączyć, to wystarczy podnieść rękę. Mamy dyskutować o od rejestracji do refundacji, zmiany, które są planowane,
the changes which are planned, the changes that have already taken place. And now we also have the pandemic on top of it. So my first question is directed to Minister Czech. The provisions of the drug policy, which is a strategic document of the government. The question is, are you satisfied with what is included in the drug policy document and what is being planned with regard to changes in the reimbursement system? Does it work well together, or do you think that there is a conflict? Thank you for this question. I would answer the following manner. Many provisions that are included there are being implemented. I am satisfied with how many changes are being introduced to the system, and that the patient's access to drugs is broader with regards to what is reimbursed from the public funds. That was always the objective of the drug policy document. I've always underlined that the patient is in the center at the end of this road. The patient and the doctor who chooses the treatment, and the system where we can find our way easily, which does not mean that I am totally satisfied. What the drug policy document was to guarantee for pharmacotherapy, that was the right level of financing, and hence the provision about 16.5 up to 17% of funds to be allocated on pharmacotherapy. And when I looked at the presentation by Magda Władysiuk, we can see now that this is not being implemented in practice. I think that Minister Wanda might agree with me that drugs are still one of the best managed elements of the healthcare system, in the way that we know what we are paying for and we know what we are spending money on. So failure to meet this condition, that is of this 16.5%, and keeping this minimum up to 17 millions, which translates into many millions or billions even of Polish zloty on drugs. That is a bit of that is underwhelming. But life has given us different solutions, because when I was writing a few years ago the drug policy, I didn't foresee the medical fund. So in the part where we focused on the innovative drugs, and we are trying to make up for the negligences for the previous years. This is the right direction, so I would like to congratulate Professor Chauderma on the idea of the medical fund. So, addressing all the questions that were asked in the previous presentation, I think that the fund which takes us towards quicker decision-making and making up for the losses and entering the horizon scanning system is best proof that we are reaching a certain maturity in how we manage the financing from public funds and in the payment for drug technologies, which brings us closer to the level of developed Western Europe countries and gives us a strong position in the CEE region with that regard. Obviously, I'm talking about certain elements of the drug policy. We can't address everything, but many aspects are being implemented the way they should. For example, the Act on the profession of pharmacists, IT solutions, broader reimbursement in drug programs, and efforts towards an evolution of the emergency drug access program. We can see that this system is in a dynamic change, is experiencing dynamic changes, and I think that this trend is a good one. You did pick up on one thread I wanted to touch upon, but I will try to address it later on in subsequent questions. Now I would like to add a short commentary before I give the floor to Director Malinowska. As already mentioned by Kamila Malinowska, the names of those parts of the fund, the TLK and TLA, are quite unfortunately similar. But this one, TLK, will function only once and will no longer be talked about. But the TLA will continue to be published because every year I hope that it will be improved. I think that this list and the system is quite similar to the postulate to introduce an egalitarian approach to orphan drug reimbursement. And basically, the first drug technology in a specific ultra-rare indication. First, we have regular reimbursement. Then we have situations with ultra-rare diseases, and there we have the first technologies with proven effects for the entire group of patients. And thirdly, we have what the emergency access to drugs should be about. That is, patients who might be in a specific health situation who need a tailored approach because they will not fit any standard solutions. Definitely not regular reimbursement and might not be eligible for drug programs or other technologies that are registered for specific indications. So these are individual situations that need to be addressed, and reimbursement in such situations needs to be granted on special conditions, taking into account the specific conditions regarding that patient. There we have very significant funds that need to be allocated, most usually, and therefore this system needs to be strictly controlled. But assuming that this list of highly innovative drugs is to be an expression of an egalitarian approach, you also mentioned registries. It's my regret that the good registry practice is not included, but we have very specific requirements with regards to the registry. So, coming to the two questions to Director Malinowska. I know that OutMeet need to fill their statutory obligations, but do you think it is realistic to be able to assess the actual practical effectiveness of those technology based on the information that you will be collecting? And second question, the needs of people with rare and ultra-rare diseases are very high. We are talking about around 720 million zloty in the special medical fund is not sufficient for the need of those patients. When do you think we will be able to find funds in the medical funds that will be sufficient to meet those needs?
Thank you so much for these questions. I will do my best to give you the most detailed answer. The first question. So, are we succeeding in assessing the practical effectiveness of the technologies which are being funded from public funds? We are perfectly aware that this is a great challenge for the HTA agency and for the healthcare system. So, without waiting for the drug technologies from the highly innovative drug lists, we are already preparing for their assessment. So the assessment of those technologies which are being reimbursed from public funds. And we have already performed some exercises in this area, and on the grounds of those, it seems probable and feasible. But we still need to do some efforts. We need to pay attention to the quality and the completeness of the evidence we have, of the data we have at hand. And we need to ensure that these data are as widely available as possible. And we also must strive to introduce the role, the function of a person who monitors the clinical trial data. And we don't have that yet. But we know that this data needs to be monitored and supervised. So it seems that a role of this type should also be performed. And as concerns the question on the use of medical funding, I don't think I'm the best person to answer, but looking at the developments in the system and looking at all the situations which we have seen and the development of the fund in Poland, I would not be concerned about spending to this end. Let us look at how the spending goes and how further allocations are made to the areas which need spending. As concerns the measures that we have at hand, the activities we have performed, it seems that the funding that is available should be sufficient for the reimbursement of the drugs we now have. We also know that these funds aren't being used overnight. They're being used up gradually in the perspective of months or 6 months, half year or yearly basis, so we can plan for their use. Thank you for your answer. And now a question with a bit of a comment as an introduction. A question to Mr. Czech. And after that, I will also like to ask the director for a bit of a comment. The relative data show that relative spending on drug reimbursement are falling. Of course, the relative expenditure is on the increase, and that's good because it gives us access to innovative drugs. But let me pose this controversial thesis that relative spending on drugs is falling while absolute spending is rising, but not as quickly as it could be going up because there's a lot of drugs awaiting reimbursement. They are on the verge of marketing authorization. They could be used in Poland if only, they do have marketing authorization, but they do not have a reimbursement decision, so they can't be used in Poland, but could be used in Poland. So all of this in the Polish system shows has the effect that spending is rising in other areas. So not in the drugs area, but in other areas of the guaranteed benefits package, because those cover other interventions and other indications. I'm not speaking about exceptions here, which are very, very costly, but these drug therapies are under good control. But we have massive spending on other areas, non-drug therapy spending. Different medical devices where the system is bleeding out, as the late Professor Jacek Ruszkowski would say. It is bleeding out on non-drug therapies, and we are only providing transfusions of blood to keep it alive. So in this context, in this situation, is it at all possible in the coming years, irrespective of COVID-19 or no COVID-19, to use the funds available in the budget? Do they lead to an increase in spending on non-drug and drug therapies? Because until we control this spending, the situation will not change greatly as concerns relative values. So a question to Mr. Czech, and I would like to ask him for his answer. Mr. Czech, I think you're muted. If you could unmute yourself. Yes, the microphone is on. Sorry, I think, yes, I muted myself to cut out the background noise, and I'm back now. Yes, thank you. And I stated this quite clearly in the introduction in my previous statement. I think we could all agree that the money spent on drugs is money spent in a controlled manner. So we know precisely in what indication, for what population of patients, in what part of the reimbursement system we are spending this money. I would even risk claiming that we are spending this money very well. So I think it is justified to further strengthen an area where we are spending this money well. And another comment, it's not about paying for everything. The head of Benelux once told me in a discussion that we shouldn't be called payers, we should be called buyers. This means that we select what we want to fund from public resources. We have thousands of technologies, but we shouldn't be interested in that. We should select what is beneficial to the patients. So the question of restrictiveness of decisions on drugs is quite clear. We should perform a selection. I will answer quite diplomatically. We have some great reserves in a system where it is not defined what we are actually paying for. When we move to the medical device areas, only some of them have a clearly defined goal of funding, and that goal is specified in the reimbursement list. But when we look at other areas, as has been said, this system is bleeding from one of its major arteries. And I'm not talking about the procedures applied in hospitals, which has been said are much more profitable. But where is the evidence of this profitability? Looking at management and at individual procedures show that the spending is very high. We can't lose sight of challenges which concern resources in the healthcare system. For example, staff, which is insufficient and which is not completely well managed, but this is a different issue. So I agree with you, and this does not follow from these limitations or focusing on one area more than another. In some areas, we are not spending money so effectively because we do not know what the money is channeled to, what the return on the investment is, what the effects of funding a specific procedure or surgery is, or some treatments whose effects are not really clear. The challenge is also the attitude of silo thinking, whether we should intervene in a more operational manner or more pharmacotherapeutic manner. And we can give lots of these examples, but so let me just end here and hand over to our moderator. Madam Director, a brief comment from you, please. The drug area is very well managed. We have some very well described drug therapies. So shouldn't additional funding be channeled there for innovation? Because the money is being spent well. We know what we are getting for our money. But no, we have a lot of funding in the system and we are channeling them to areas which are bleeding out from major arteries. So a comment here, please. Thank you very much. What I can say is that the next panel will discuss the guaranteed benefit package in detail. Director Dziurda will give us an exhaustive commentary on this issue. As concerns drug assessment by the Polish HTA agency, then I can risk the thesis that I do not agree with you completely. I do not agree that we could spend more at this precise moment on drugs than we are spending now, because we do not really have a well-surveyed market and defined areas where we could channel more funding. So the lists of drugs with high clinical benefit or highly innovative drugs give us some opportunities here, but we are actually quite reactive to these areas of drugs and non-drug areas. Not everything has been well analyzed, and it is not always possible to determine the funding that could be channeled to drugs. Another thing is that the medical fund is not really so much of horizon scanning, because we are looking back. We are not looking only at prospective additions to the list, but we are also looking at what we have available now. And this is consistent with the reimbursement pathway, because we are looking at applications submitted by responsible entities. We want to accelerate this procedure from the moment when a molecule is development to its reimbursement decision. I know that Mr. Czech, the minister, would like to present his arguments, but let me just step in, because I believe that I could spend 10 on 15 million zlotys with light-handedly on drug therapies registered in Europe by EMA. There's more than 880 drug therapies which have been authorized for the market but are not reimbursed in Poland. And also, as concerns emergency access to drugs, I could immediately spend 20 billion zlotys on that. And it will be spent in a better way than the investments for the benefits, for the guaranteed benefits package, because we are pumping money into the package without any sense. We are spending this money unreasonably, and it is based on unsound criteria. And this is what the ministry and agencies should be doing. And the last commentary from Mr. Czech, and then we close the session. So my general comment is that we do not have enough time for this discussion, and it is only starting to become really lively. And a commentary to Madam Director. I get the impression, please correct me if I'm wrong, is that the high clinical benefit drugs is a sort of catching up of the delay we have in the reimbursement system. But the question is, your comment, Madam Director, on spending money is about going back to all technologies which are on the reimbursement list and perhaps should not be there. So a review which is aimed at making savings. Is that the case? I'd like you to comment on this. If so, then I completely agree. But on the condition that the savings made by this process are channeled back to innovative solutions needed by patients, and that this will be part of reaching this threshold of 16.5%. I don't know if I could spend so many billions. I would find it difficult to take decisions so quickly, but a couple of billions I think would be spent best in early response in pharma therapy, and I think that would be the best solution. Madam Director, would you like to respond to this? Of course. The amounts you've listed are more or less consistent with what the Polish HTA agency has estimated. But in response to what Mr. Czech said, the task I had in mind was about looking at technologies are outside of the reimbursement system. Okay, thank you for that clarification. And we have President Władysuk back in the studio. Thank you to everyone. Thank you, Marian.
Thank you, ladies and gentlemen. I think that the discussion could go on, and I hope that next time we can have more time to discuss reimbursement of drugs in Poland. We could give a full session on that. I think in Poland we can talk more and more openly about what is changing for the good and what is changing in the wrong direction. We are running a slight delay, so in 10 minutes we will be inviting you to our second session about quality as a chance to increase opportunities